You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for December 14th, 2018. This week, carotid stents, retractions, statin safety, flu shots, medication errors, VA healthcare, and wasteful research. First, let's talk about carotid intervention. 2 studies published in JACC Interventions addressed mesh-covered stent technology for doing these procedures in the carotids. The idea here is that a mesh-covered stent might keep the small particles of plaque that can be released during or after the stenting process from entering the circulation. Of course, the design changes to prevent one problem with a stent can lead to others, such as restenosis or difficulty with deployment. And that's why you need studies. So the first paper, called the scaffold trial, it's not really a trial because it only had one arm, no control arm. The scaffold reported outcomes with this novel mesh-covered stent. They did this procedure in about 300 patients and found the 30-day rate of death, stroke, or MI was 3%, and the 30-day stroke rate was pretty low at 1.1%. Now, the second report in JACC Interventions was a patient-level meta-analysis of 4 trials of about 550 patients with 2 different dual-layered mesh-covered stents. And again, these are single-arm studies. The patient characteristics in the meta-analysis were similar to the scaffold trial, although I will say that both trials had pretty high rates of patients with asymptomatic stenoses. Around 80% have no symptoms. In these 4 studies in the meta-analysis, the cumulative 30-day mortality rate was super low, 0.2%, and the incidence of stroke at 30 days was 1.25%, again, pretty low. So I spoke with a vascular surgeon at my hospital, and he said mesh-covered stents will probably represent an improvement for symptomatic patients whose plaque has already shown a tendency to embolize. Now, I can only comment on these studies from a methodologic perspective. I'm not a vascular surgeon, but the problem with carotid stenting is that previous studies show comparable outcomes to carotid surgery, but in asymptomatic patients, which are the majority of carotid interventions. I have prepared talks arguing that carotid endarterectomy is not likely any better than contemporary medical therapy. So then why are we doing so many carotid interventions in people without symptoms? Now, perhaps you could argue that new iterations of the stent and the stent technology, for instance, this flow reversal and filter devices, which are fascinating, may prove that intervening on carotids will be better than medical therapy, but that needs to be tested in a trial. For patients with carotid disease and symptoms, intervention can surely be helpful, but these new iterations of stent technology and intervention need to be tested in proper trials, not single-arm studies with no control groups and comparisons with historical controls. Now, here I can brag about my field of electrophysiology. I mean, we needed to answer the question of which was better for AF ablation, cryoballoon or RF. Well, the fire and ice investigators did a large, proper randomized controlled trial and found that the 2 different techniques were similar. Second topic today is more news on the stem cell retractions. Now, this week, Circ and Circ Research retracted 13 papers from the now defunct laboratory of cardiac stem cell researcher Piero Anversa. Now, here is the key phrase that caught my eye in this update. Quote, after considering input from the authors, the AHA has determined that the best interest of the public and research community will be served by issuing this notice of retraction. I highlight the phrase, quote, after considering input from the authors, because fraudulent studies affect all the authors who signed off on a paper. Now, the stem cell retraction story is big, not just because it affects a major and formerly hopeful area of cardiovascular research, but also because it is bringing the integrity of science to mainstream news. There's just a lot of news. So every time I see something like this, I think of the DECREASE trial led by the Dutch researcher Don Poldermans, who's had multiple sanctions. The DECREASE trial was bisoprolol versus placebo before surgery to prevent cardiac events. Now, whereas all other preoperative beta blocker studies have failed to show a net benefit, the DECREASE trials did, but the problem is that the group of Daryl Francis at Imperial College have shown that decreased results were likely made up. And the New England Journal has an editor's note of concern on this publication, but there it is in the published literature. I wonder someday if increased attention on retractions might prompt retraction of the decrease trial. And it's a big deal because I'm still occasionally asked whether or not to give beta blockers for preoperative cardiovascular protection. Next topic is statin safety. Now, I covered this a bit last week when a modeling study that was published in Annals of Internal Medicine came out, and this modeling study took into account statin adverse effects, and it suggested that we should have a higher threshold for cardiovascular risk before starting statins. But soon after the podcast went up last week, the AHA issued its first scientific document on statin safety. And once again, Patrice Wendling has a super recap. The major themes of this new scientific document are that statins may increase the rate of hemorrhagic strokes, especially when used in secondary prevention, though crucially, these risks don't outweigh the benefits. Second topic is that muscle complaints in blinded RCTs of statins show no greater muscle effects than in the placebo arm, whereas statins in observational studies are associated with higher rates of muscle complaints. Of course, the only way to answer the question once and for all on statin muscle issues are to do a bunch of N of 1 trials where a patient is his own control. The patient first takes a blinded placebo, then a blinded statin, then a blinded placebo, and back and forth, and you can answer this question. I'm pretty sure that the Imperial College Group is conducting such a trial. The third theme on statin safety is that much of the data on safety comes from short-term studies, and this reiterates the worries of Professor Hayward that I talked about last week about the unknown unknowns of long-term statin use. And finally, the diabetes issue gains mention in the document, but as Dr. Richard Lehman has written multiple times, the higher rate of diabetes with statins is mostly due to a lowered cutoff for diabetes diagnosis. The real story is that statins reduce cardiovascular outcomes, especially in people with diabetes. Finally, the more and more with statins, I believe the answer is just to put these things over the counter and let people decide. I mean, they are surely as safe as nonsteroidal anti-inflammatory drugs, and people can look at the benefits and harms and decide for themselves. Next topic, I wanted to detour away from cardiology just for a second, and this is about the issue of mandatory flu vaccine or flu shots. Medscape had an interesting survey on whether flu shots should be mandatory in healthcare facilities. Now, reports of healthcare workers being fired for refusing flu vaccine has sparked interest. And my interest in this topic relates to the intersection of evidence, policy, and liberty. First, let me set out that I recommend strongly to my older patients with heart disease that they should get a flu shot. They are vulnerable, and though the benefits in absolute terms of this vaccine is small, I see little downside. The issue here I have is with mandatory flu shots. That is, forcing people to give up their right of informed consent should require a high bar of evidence. A flu shot has a very low risk, but it isn't zero. Now, I have looked and I've studied this, and I can find no evidence supporting mandatory flu vaccine as a patient safety metric. I think the mandatory flu vaccine issues is a distraction to the real issues. For one thing, there are hundreds of infectious pathogens that healthcare workers could transmit to vulnerable patients. An influenza vaccine can prevent only one, and its degree of prevention varies a lot. A real patient safety measure would have policies in place to let workers stay home when they're sick. But that's a hard policy. Stomping around about flu shots is easy. And I don't think this is just an academic argument. When the CDC and hospitals spend energy creating fear and hyping therapies with tiny absolute benefits, the harm is distraction from important stuff. Okay, by the way, despite a near infinite NNT, I got a flu shot this year, even though I wasn't forced. Next topic is medication errors. Now, speaking of distractions and important stuff, a report from Wales chronicles errors in giving out medicines in acute care settings. These researchers looked between 2007 in 2016 and wrote that more than 500,000 medicine errors were reported, and 229 of these caused death, fatal medicine errors. The most common fatal error category was an omitted medicine or ingredient. Most common drug groups were cardiovascular and nervous system. The authors concluded that we needed, quote, interventions to prevent these most serious errors. Now, of course, a descriptive study doesn't inform us which interventions work. But I know what does. Trials do, studies do. You can study these things. One intervention I'd like to see is a trial of decreasing warnings in the EHR. Now, I don't know about your EHR, but one of the most dangerous things our electronic health record system has created is warning fatigue. Because there are so many, and most are totally frivolous, people just click through them. Here's another potential thing to study, another intervention I'd wonder about is education policies about what constitutes drug allergies. Again, true allergies are being washed out by people writing someone is allergic to opioids because they got nauseous or itchy, or allergic to beta blocker because they got a low heart rate. Now finally, if I wanted to minimize errors in the hospital, I'd do everything possible to increase the number of well-rested, non-distracted caregivers who had the bandwidth to focus on the job at hand. Next topic is about VA care, veterans care. Now, one of the big healthcare debates going on in the U.S. right now is whether we should move to a single-payer Medicare for all system. But liberty-minded Americans worry about government-run care because we hear about wait lines and substandard care. The VA health system here in the U.S. is a closed government-run system. And a recent report in the Annals of Internal Medicine compared VA and non-VA hospitals within specific geographic areas. They measured 15 commonly reported outcomes. And when they considered all regions together, the VA healthcare was significantly better. That's better than non-VA care for 14 of the 15 measures. And now this confirms the findings of numerous previous studies that the authors cited. A VA hospital provided the best care in at least 50% of the regions for 9 of the 15 measures, above average care in at least 2/3 of the regions for 14 measures, and they were worst in care in only 15% of the regions for 14 measures. While there will always be questions about the robustness of these sorts of data sets, these findings suggest that the idea that the veterans, a closed single-payer system, got worse care than people in the private system is simply not borne out by the evidence. Final topic, I wanted to discuss a research on golf. 4 Harvard researchers publishing in the BMJ reported an observational study of the proportion of physicians who played golf, their handicap, and their specialty. They looked at millions of physicians and found about 4% play golf, and they concluded after this pretty extensive study that golfing is common among U.S. male physicians, particularly those in the surgical subspecialties. Now, what caught my eye about this exercise was the line at the end of the news story, quote, "Support for this research was provided by the National Institutes of Health." Now, have you ever seen videos of American politicians grandstanding about cutting research dollars for science? What they do is they cite silly studies like this. In 2014, Lancet had a whole journal on increasing the value and decreasing waste in research. I'd say the scientific endeavor, ladies and gentlemen, would be fine with fewer studies on the golf habits of physicians. So that's it for this week in cardiology. I'm grateful that you listened. Thank you. Again, if you like this podcast, please consider subscribing, giving us a 5-star review. This way, other people can find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.